This section is going to focus now on the sequencing approaches for relapsed and metastatic renal cell carcinoma. And I think whenever we discuss switching from frontline therapy to subsequent therapy, we have to start with how we're defining disease progression. So Walt, outside of RESIST, which is used in our clinical trials, in your practice, how do you define disease progression?
I think you have to look at the CT scans, right? And I think that especially with the variability in radiology reports, it is not just the bottom line that says progression, it is what does this look like not only compared to the immediately previous CT scan, but to the CT scan that was done at baseline of this therapy. So we sometimes see patients where the radiology report says progression, but progression is, a few millimeters on 3 lymph nodes. That's not real progression. Continue with the therapy. Patient is doing well. We sometimes see reports that say no progression, but the patient has been on the same therapy for 9 months, and you actually look at the CT scan from 6 months ago, and it's pretty obvious that there has been a significant growth in the cancer. So I think that, yes, we need to work closely with our radiologist, but we need to look at the CT scans along with the patient.
And I totally agree with that. Radiologists do what they do well. Current scan, what was the last scan? But they don't go back, and he's correct, what is the baseline scan and what are the changes that have taken place? And has the tumor progression slowed down from prior to starting? Were these individuals more rapidly progressing, started medication, and you put the red light on there? It's slowing down. It may not be reversed, but it leveled off, which is, and no new diseases developing, right? Which is how I look at it, and it sounds like Walt looks at it very similar.
Yep. And Toni, when you think biologically at disease progression, do you think of existing lesions increasing incrementally as different kind of progression than when you see new lesions or particularly new organ sites involved?
I do a bit, depending, but then new lesion could double in size, or everything can be stable and you can have one new lesion, which I usually ablate or remove surgically, not myself, my colleagues, of course, I wish, and keep on the same treatment. So I think I wouldn't give the example that Walt gave, how do you know progression, but I would say it's almost like surgery. There are templates, there are textbook written, how do you do surgery, appendectomy, but at the end of the day, it's really, you cannot, it's the surgeon does it. So we sit down, it's really at the core of a medical oncologist and someone dealing with cancer, urologist here, that can tell you progression or not.
And Rich, what about clinical progression? Now, when we see clinical progression, is that different than radiographic progression in your mind, prognostically and in terms of management?
Yeah, I was going to say that was the one thing that scans, for me at least, tell a part of the story, but the most important part for me is the clinical progression. So if a patient goes up by several millimeters, but his performance status is greatly decreased or something's else going on that's leading me to believe, that to me is more important, and those usually go along with other signs that you can see in the blood work, paraneoplastic, more worsening anemia, LDH, calcium. Sometimes those are out of proportion to what the scans show. So it's a three-pronged picture. I think it's the clinical status, it's the scans, it's the labs. And I agree that there are different types of progression. The ones that have new lesions are usually typically go along worse than having growth of old lesions. But I agree, it's not some textbook. It's a bit of an art, and there's not an infinite amount of treatments that we have. So I try to milk everything I can out of each treatment before trying to switch to the next one.